Dr. Leon Schurgers, he's Associate Professor of Biochemistry and Senior Scientist at the Department of Biochemistry at the Cardiovascular Research Institute of University of Maastricht. Dr. Schurgers' research line involves the elucidation of molecular mechanisms of vascular smooth muscle cell-derived vitamin K-dependent proteins by which vascular calcification is initiated and propagated. Our second speaker will be Dr. Katarzyna Merez. She is the president of the International Science and Health Foundation, obtained a degree at the Faculty of Pharmacy at the, I'm telling you, all of these words are just throwing me this morning, Jagiellonian University, and has a doctorate in biological sciences. She served as postdoctoral fellow in the Laboratory of Cellular and Molecular Immunology, there you go, Blood Research Institute, Milwaukee, and has been part of a research project co-funded by the European Union. Dr. Schurgers, I'll turn things over to you.
Can you hear me? Good morning, everybody. It's a pleasure to be here. It's a pleasure to be invited to speak here at the Vitamin K2 Workshop. And actually, it feels like being a little bit a rock star. You know, I'm from the scientific field, and normally you speak at scientific meetings. But being here and in the field of vitamin K, it feels really like a rock star. And I saw Robbie Williams doing this. He's making pictures, you know, when he's giving a concert of his audience. So I want to do that as well. I never had this opportunity. So all smile. Hey! Okay. But we are not here to play rock stars. I'm here to educate you a little bit on vitamin K. So I entitled my presentation MK7 as a novel treatment option for cardiovascular disease. And I want to try to convince you in the next 30-35 minutes why I think that vitamin K2 might be a really treatment option for cardiovascular disease. Well, when I started my research in the university, that's back 20 years ago, calcification was not really on the radar. You know, calcification was just a passive bystander, and cardiologists, internal medicine, nephrologists, they were just aware of the calcification, but they didn't do anything with it because it was just the precipitation of calcium and phosphate salts on, let's say, cellular debris, and it was not really of interest. However, together with a PhD student of mine, who is now working as an internal medicine doctor in the Maastricht University, we did a meta-analysis, and we screened for calcification at any vascular site in our human body. And actually what you can see is that all studies which we screened, they show that if you have calcification, you have a risk on any cardiovascular event. So dying from a cardiovascular event, higher chance if you have calcification wherever, carotid artery, coronary arteries, aorta, but also peripheral arteries. And the odds ratio is 3.4. So you have a 3.4 higher chance of dying if you have calcification in your arteries. Actually, this was becoming really aware now in the medical society. And it's not only in our laboratory in Maastricht, but also here in the United States. Paulo Raggi, he is a famous cardiologist screening calcification in coronary arteries, and he says that the coronary artery calcification score is a better predictor for cardiovascular events than the complete Framingham risk score, which includes age, gender, smoking, cholesterol, hypertension. So calcification really is now on the radar, and it is used as a measurement for cardiovascular disease all the time. So actually what we are looking for is calcification, and this is just a picture of how your washing machine looks like if calcification takes place. But also in our human body we have diseases where calcification really takes place. We have hypercalcemia. This is calcium levels in the circulation higher than 2.8 millimolars. Hyperphosphatemia higher than 2 millimolars. We have atherosclerosis. So locally in the vessel wall, we have calcium concentrations higher than 30 millimolars, which is really, really high. So normally we have 2.45 in our bloodstream. End-stage renal disease, where the calcium and phosphate product is increased, and calcium phosphate, maybe you still know that from your chemistry lessons, they're not really going together, you know, they precipitate. So we need cellular systems, we need proteins to inhibit that precipitation. And then with hypertension, the intracellular calcium load is really high. So the precipitation of calcium salts happens at pathological sites, and mainly that is in the vasculature. So actually where we are looking for is the bleach. Can we inhibit, can we prevent calcification, or when calcification is there, can we reduce it or halt the progression of calcification? I have to tell you that calcification in bone is an active mineralization process, building bone but also resorbing bone, and my belief is that the calcification in the vasculature is an active process, and so also the resorption of calcium from our arteries should be and must be an active process. So I did my PhD back in 2002 in Maastricht on vitamin K and the differential effects on vitamin K1 and K2. And actually I was the first one who discovered that vitamin K2 had other functions, better functions than K1. So it was not me that discovered vitamin K, it was a European guy from Denmark, Hendrik Dam, and what he did is he fed chickens a fat-free diet. And by doing so, all these chickens were bleeding to death. So he substituted cholesterol, it wasn't the cholesterol, he substituted all kind of micronutrients, fat-soluble micronutrients, and suddenly he isolated one nutrient which prevented the bleeding disorder. And because he published this in a German journal, he called it the coagulation factor, and coagulation in German is written with a K, and from that time on, vitamin K is known as the coagulation vitamin, whereas I would rather name it the calcification protein. Up to now, we have 14 vitamin K-dependent proteins which are discovered. The most known are, of course, from the coagulation cascade, factor 2, 7, 9, and 10. And a clear function of vitamin K, besides also playing a role in the redox cycle, is, of course, that it activates vitamin K-dependent proteins. I will come to that in a minute. And we have, of course, vitamin K1 and K2, which is found in green leafy vegetables or in fermented foods. So what is the real function of vitamin K? Vitamin K is absorbed via the food. It's a vitamin. It's a vital amine, so we need it to take it via the food. And vitamin K is taken up by the bloodstream in the intestines. It's incorporated in chylomicrons. And then it's transported to the endoplasmic reticulum in cells where we need to carboxylate, activate vitamin K-dependent proteins. Okay, that animation works. Here it doesn't work. So vitamin K needs to be reduced to the reduced form of vitamin K, which is the active cofactor in the carboxylation reaction. Now, what does vitamin K do? When it is oxidized, it provides the energy to put in an extra carboxyl group in certain glutamic acid residues, protein-bound glutamic acid residues, and carboxylates them. It gives them an extra negative charge, and by this extra negative charge, it can bind calcium to, for example, negatively phospholipids, or it can nucleate calcium and shield binding sites. So why is it that we need minute amounts of vitamin K? We need only micrograms in the diet and not milligrams, like, for example, vitamin E. That is because vitamin K is recycled, and in this way, one molecule of vitamin K can assure 1,000 of these carboxylation reactions. So one molecule of vitamin K ensures 1,000 of these carboxylation reactions. Nearly the same time that vitamin K was discovered in Europe, in Wisconsin, there was a substance that was discovered which made that cows, which were dehorned, were bleeding to death. And although it was discovered in America, it was a German pathologist that discovered this disease. And he isolated one micronutrient, again, which was warfarin. And actually, warfarin stands for Wisconsin Alumni Research Foundation, with Aaron from coumarin. Coumarins were first launched as rat poison, so actually what we are doing in our clinic is treating our patients with rat poison, and that was because in 1951 there was a US soldier who wanted to commit suicide, and he took a lot of warfarin, but then he thought, well, shit, I want to live. And because the onset of warfarin is a few days, he could go to the hospital, and they could give him vitamin K to rescue his bleeding phenotype. And actually, by doing that, the medical doctors realized that we have a very strong anticoagulant. And that is where the rat poison became a medical substance. And actually, in 1955, Eisenhower was one of the first famous recipients of warfarin. So what does warfarin do? What is vitamin K antagonist? Do they inhibit the absorption of vitamin K? Well, no, they don't inhibit the absorption of vitamin K. Vitamin K is taken up by the intestines, it's transported in the blood, it's going to all the target tissues. And also, it does not inhibit the reduction of vitamin K becoming an active cofactor. So what does warfarin do? It actually doesn't even inhibit fully the carboxylation, but what it does, it inhibits the recycling. And in this way, giving vitamin K antagonist to a patient, you make sure that one molecule of vitamin K only creates one GLA residue instead of thousands. So you decrease the vitamin K levels in the tissues, and thereby you increase vitamin K insufficiency. And this is what we want to do, of course, because patients that have hypercoagulability, you want to lower the blood clotting. But what was realized is that it not only affects the blood coagulation, it also affects other proteins, such as matrix GLA protein. And that is something what we realized, and I just show you here one example. We used warfarin, vitamin K antagonist, in mice. And by doing so, we first wanted to know what is the optimal dose. So we gave different treatment regimens of vitamin K1 together with warfarin. And what we found is that you need at least 1.5 milligram vitamin K1 plus extra warfarin, and then you prevent the bleedings of the mice, because if you go lower with vitamin K, all the mice died due to severe bleedings. But what you create is a severe vitamin K deficiency in the vasculature, thereby inducing calcification. So this is what we found, is if you use 1.5 milligram of vitamin K1, and on top of that you titrate extra warfarin, vitamin K antagonist, in the diet, the higher the dose of warfarin, the more calcification you find back in the vasculature. If you do it for a longer time, so over time, baseline versus 7 days, 28 days, or 49 days of warfarin treatment together with vitamin K1 in these animals, then you see that the calcium load is already increased after 7 days of warfarin feeding, whereas the first visible signs, and everything here in black, these is a von Cossa stain. It's a specific stain for calcium phosphate in the vasculature. And everything which is black is calcification. So you see that after 28 days, 1 month, you see already dramatic calcifications in the vasculature of these mice. This is medial calcification. But of course you want to ask me, okay, this is a rat poison. Of course it does make calcification, creates calcification in the vasculature. This is not the human situation. So this is where we collaborated with Harvard University a few years ago, and this is a patient which developed severe end organ failure. So this patient had to go on dialysis, and he was placed on warfarin. And so what they did, medical doctors, they did a CT scan when he came into the hospital. And he was treated for 9 months with coumarin, and what you can see is that, and unfortunately, this patient died, but what you can see is here all these white spots. These are calcifications in all the large medium arteries of this patient. So if you ask me what is the onset of calcification in vitamin K deficiency in a patient, it can be as quick as 9 months that you are calcified in all your arteries. Another example is calciphylaxis. Calciphylaxis is a deathly disease, mainly occurring in dialysis patients, but not limited to. And what these patients develop is complete calcification of the large arteries, which you see here, the small arteries, but also of the skin arteries. So this is completely calcified skin. And what is very interesting in this disease is that 50% of the patients receives warfarin. So in this calciphylaxis disease, dramatic calcification, 50% of the patients is on warfarin, has a very severe vitamin K deficiency. And finally, we also did a study with the cardiology department in our Maastricht University. This was published in the European Heart Journal, a very high-ranked medical journal. And what we did is we looked in atrial fibrillation patients, but with a very low risk on developing, on having that. And actually, the treatment for these patients is a little bit unsecure. You know, we don't know exactly what to do, but warfarin is safe, vitamin K antagonist treatment is safe, so give it. So what we did is we used patients younger than 65 years or older than 65 years, which were either not on vitamin K antagonist for 6 to 60 months on vitamin K antagonist or longer than 60 months on vitamin K antagonist. And we stratified according to the Framingham risk score, so all patients had the same baseline risk score. And what you can see is that those patients which were not on vitamin K antagonist treatment had no calcification in their arteries, whereas those which were on vitamin K antagonist, they had a Gadsden score between 100 and 400, and Dr. Goodman already told us that that is a very high score. It's even more dramatic in the elderly population, whereas here, those patients not on vitamin K antagonists, the majority of them, 50%, had no calcification in their arteries, whereas those longer than 60 months on vitamin K antagonists, 50% of the patients had an Gadsden score over 400. Very indicative that vitamin K deficiency really induces calcification, also in humans. So what is causing this vitamin K deficiency? Well, for a long time it was not known, but then it became clear that this protein, matrix GLA protein, is a vitamin K dependent protein inhibiting vascular calcification. Well, the protein was discovered in bone and 1980s. And everybody was thinking, okay, we have another bone protein in hand. So researchers here from New York, they created a so-called matrix GLA protein knockout mouse. So what you do is you take the DNA of the mouse, and then you take out the gene that encodes for this protein, you put back the DNA, and these mice are born normal, born to term, however, miss this protein. And actually the researchers were looking for a bone phenotype. However, all mice were born normal, but all died within 8 weeks after birth. And what happened when they gave these mice a closer examination, they saw that this is not the spine. Everything in red is calcium. This is the aorta. These are all the large vessels. So all large vessels were completely calcified if you lack this protein. And from that time on, everybody knows MGP is one of the strongest inhibitors of vascular calcification. So what we did, or I did during my postdoc period, we created MGP antibodies. And with these MGP antibodies, we could really detect the inactive form or the active form of matrix GLA protein. And what you can clearly see here from this section, this is a human section of a peripheral artery. You see here the calcification spots along the elastic lamina. Everything in black is calcium again. And here, this is the inactive form of matrix GLA protein, co-localizing with the calcification. Of course, you can speculate that either calcification induces vitamin K deficiency leading to inactive MGP, or that the inactive MGP really makes that the vessels calcify. And I foster the latter hypothesis, because with the vitamin K antagonist, we induce uncarboxylated MGP and thereby calcification. Everybody says that calcification is a very late stage of cardiovascular disease, and I disagree. And I disagree because we did a study together with our Department of Physiology and together with the Technical University in Eindhoven in the Netherlands, where Philips, for example, is located, all known to you. And what we used is we used atherosclerotic plaques from patients, which we divided in a type 1, type 2, type 3, type 4 lesion. Type 1 is, let's say, the healthy artery. Type 2 is a little bit of lipid infiltration. Type 3 is already inflammation. Type 4 is a little bit more advanced, and you get already a really stenotic lesion. However, calcification is always thought to be a very late stage, let's say in type 5 plaques, before it can rupture. But what we did is we did with a proton microprobe, which you can do element analysis on a microscale. And what we found is that calcifications are already in the healthy vessel wall, and that is calcium phosphate in a ratio of hydroxyapatite. So you find the first calcification already in a type 1, more in type 2, 3, 4, and it nicely correlates with inactive MGP, suggesting that a vitamin K deficiency leads to microcalcifications, and these microcalcifications are the start of all the cardiovascular events in later life. So we want to prevent these microcalcifications, we want to prevent calcifications in our vasculature. And actually, because vitamin K is so important, together with my colleague Martin Shearer from King's College in London, we wrote a book chapter. And we started the chapter that a vitamin once regarded as the Cinderella of fat-soluble vitamins emerged from a single function hemostatic, so coagulation vitamin, to a multifunction vitamin, and arguably the most fascinating of all, and that is vitamin K. So I started my presentation that you have two forms of vitamin K. You have vitamin K1 and you have vitamin K2. And actually the work I did during my PhD was that I asked volunteers to eat spinach together with natto. And natto is, of course, the fermented soybean, very rich in MK7, and we measured the amount of MK7 in the natto, and we measured vitamin K1 in the spinach, and that were equal amounts for breakfast. And it was very difficult to find these volunteers to eat 200 grams of natto. So here, at baseline, patients or people, volunteers, had to eat 400 grams of spinach with 200 grams of natto, which equals 1 milligram of MK7, 1 milligram of K1. And what you can see is that K1 is very poorly absorbed, and that is what we already knew. 90% of the vitamin K1 from the food ends up in the toilet, only 10% is absorbed, whereas MK7 was absorbed very good. It is a 10 times better absorption
not polite to skip
than for K1. But the second thing which you can see from this means that vitamin K1, K2, and K7 they are taken up from the liver and then redistributed in the plasma and being available for all the extra hepatic tissues such as bone and vasculature. And this is really necessary because K1 is going to the liver and it makes that the coagulation factors are activated there, but there is only a little bit left over for all the extra hepatic tissues. So this is what we used, and this is a very busy slide, so I will try to guide you through it. We used mouse models, and these mouse models, they are genetically modified so that when you give them a McDonald's diet, so a high cholesterol diet, they all develop atherosclerosis. And what we could see is that if
you're watching Fox 45 Morning News, all local, all
significant increase in calcification. So this we have now proven over a dozen times, and also other groups. And if you give then a low dose of vitamin K and you stop the warfarin, then you see that calcification, once it's present,
you're watching Fox 45 Morning News.
All once calcium is there, it keeps on growing. However, when you give high dose of vitamin K2, you see that there is a reduction of 37%. So this is very speculative, that vitamin K2 can reduce preformed arterial calcifications. This was published in the journal Blood in 2007. Recently, we collaborated with the clinical university in Aachen, Germany, and we showed that also in another mouse model, in a DBA2 mice, when you give vitamin K2 on top of the K1 and the warfarin, you could completely inhibit vascular calcification in the arteries of these mice, suggesting that vitamin K2 is really a good treatment option to inhibit, but also to regress preformed arterial calcifications. And a very recent study with MK7, which was published in the journal Nutrients 1 month ago, we showed again that high dose of MK7 could reduce calcification, and this is a mouse model, a rat model for CKD, chronic kidney disease. So in these patients suffer from a lot of calcification. The treatment with MK7 could reduce the calcification, but more interestingly, it also increased the expression of MGP protein. So MK7 does more than only activating it, it also makes that there is more secretion, production of MK7, and this is the first study showing this. This slide has already been shown by Dr. Goodman, and I will briefly go over it. This goes back 10 years ago, where we collaborated with the Erasmus University in Rotterdam in the Netherlands. And they have a very nice population, which is called the Rotterdam study, and I did a lot of measurements of vitamin K in food, and we coupled our food analysis, our database, to their patient population. And these are all healthy elderly, they are followed up every year, and finally nobody survives this study because they just follow up till everybody dies. And this is the first 10 years of follow-up, and we divided the vitamin K intake into tertiles. Vitamin K1 had no effect at all on cardiovascular disease. However, what we saw is that the highest tertile of vitamin K2 intake, mainly the long-chain menaquinones, MK7, 8, and 9, had a 50% reduction of arterial calcification, had a 50% reduction of cardiovascular death, and a 25% reduction of all-cause mortality, which is logic because 50% of all mortality is based on cardiovascular death. So this was a first study. It was very difficult to get this published because nobody believed it. It was too good to be true. And there was also another study in the Netherlands where we were not involved, and they showed that for every 10 micrograms of long-chain menaquinones, MK7, 8, and 9, there was a decrease by 9% of cardiovascular risk. Indicative that vitamin K2 is really decreasing calcification and thereby preventing cardiovascular disease. A new study which we initiated together with the vascular surgery department in Aachen, Germany, is that dialysis patients, they have 3 times a week they have dialysis. And for that, they connect the dialysis machine via a vascular access, and that needs to be an artery. And this artery normally is very difficult to access, so what they do is they take a venous vessel and they connect that to the artery. And by doing so, you can then easily connect the dialysis machine to this venous artery. But there is a clinical problem. This clinical problem, that is, there is 63% of these vascular access, they are not useful anymore after some time. So what people do, what does the clinic do? We give warfarin, vitamin K antagonist, to keep this vascular access open. So what we did is we developed a rat model in which we studied this phenomena. And briefly, what we saw is, and this study will be published in the Kidney International Journal next week, what we saw is that with warfarin, you made the disease worse. More calcification, more neointimal hyperplasia. So we switched, instead of warfarin, to vitamin K2, and what we saw is we could have a complete prevention of the calcification in this vascular access, and also prevention of neointimal hyperplasia. And actually, the medical doctors themselves, they concluded vitamin K2 should be regarded as a therapeutic approach to prevent neointimal hyperplasia and calcification in vascular access. So I think we have some breakthroughs. So then the question, where do we get our vitamin K2 from? Well, of course, we can eat natto. It's a very rich source. But what is natto? Natto is a fermented soybean. Actually, it's a rotten soybean. And how does it taste? It tastes like rotten soybean. So it's not a very nice thing to appreciate. At least in Japan, it's very appreciated. Outside Japan, not many people like it. What else can you do for vitamin K2? Well, go to the zoo and look what chimpanzees do. They eat their own feces. It's full of vitamin K2. We can do that. But, well, actually, nobody wants to do that. So thank God there are companies that now have supplements enriched with MK7, so we don't need to go to the toilet and eat our own feces, or we don't need to eat natto, we can just take supplements. And what we did is we used these supplements for a dose-finding study, and this dose-finding study was published a few years ago, and we wanted to know what is the optimal dose. This is in young, healthy volunteers, and we saw that 180 micrograms of MK7 is optimal in carboxylating osteocalcin. So that was used for a 3-year clinical trial, and Dr. Goodman already briefly showed this, and I will go over it very briefly. 244 participants, MENA-Q7 versus placebo intervention study, 3 years with a daily supplement, 180 micrograms of MK7, MENA-Q7, standalone, so no calcium, no vitamin D supplementation, and the endpoints were DEXA, so bone mineral density, vascular health, pulse wave velocity, intima media thickness, and the body weight. And the measurements were at baseline 1 year, 2 years, and 3 years. So what we saw is that the intima media thickness, and Dr. Goodman already explained it, it's a measure, it's a clinical measure for how healthy your arteries are. And what we could see is that MENA-Q7 could completely preserve the vascular health, whereas the placebo decreased in vascular health. So this study was the first study to show that vitamin K2, MK7, MENA-Q7 in this study could prevent the loss of vascular elasticity. Actually, it made the vessels more elastic because it prevents calcification there. A second measurement is the pulse wave velocity. And with the pulse wave velocity, you measure the speed of a bolus blood from the carotid artery to the femoralis. And the quicker the traveling of the blood, the stiffer the vessels are. And actually what we saw is that MK7 reduced stiffness of these arteries. And MK7 was the first treatment option that you could reduce arterial stiffness. So this is in healthy volunteers. But also in patients, also the cardiology department, internal medicine, they are now very aware that MK7 could be a treatment option because clearly statins, they cannot inhibit calcification. And many drugs have been tested to reduce arterial calcification because it's really a hot topic at this moment. So this is a study sponsored by the Dutch Heart Foundation and by NATO Pharma. We have 200 patients to include 100 placebo, 100 on MK7, MANAQ7 for 360 micrograms for 2 years. At this moment, we have 120 patients enrolled because these are patients, these are screened in the cardiology department in our hospital, and they have an Agatston score between 50 and 400, and then they are treated with either placebo or MK7. And the endpoints, the primary outcome endpoint is the progression of coronary artery calcification. There is a second study which starts now. Actually, we have now medical ethical approval in which we want to study the effect of MANAQ7, 360 micrograms on aortic valve calcification because that is a huge clinical problem as well. This is also a study in which we also will include PET MRI, a new sodium fluoride 18 PET probe, which measures active mineralization. And this study is now more or less up and running. So I think you will hear more and more about vitamin K2, MK7, in the upcoming years. The clinic is getting interested in it. The nephrologists are interested in it. And I think if we can prove that MK7 can reduce arterial calcification, that would be a really step forward in the medicine. So finally, I want to thank my sponsors because I need money to conduct all my research. And I want to thank especially the Dutch Heart Foundation, but also NATO Pharma for providing and supporting me for over 10 years already. Thank you, and I'm more than happy to address questions.